Bismillah, alhamdulillah, wa salatu wa salamu ala rasulillah. Dear colleagues, I'm happy to be with you today. I'm Dr. Khalid Tayib. I'm a consultant diabetologist at Al-Noor Hospital, Makkah al-Mukarramah. I will discuss with you today how to manage our patients who fast during Ramadan. The topic is very important, as you know, as most of our patients fast during Ramadan, and sometimes they even fast outside Ramadan. The content of my lecture will be, I'm going to be giving a little bit of introduction about how many people around the world fast Ramadan. We're going to talk about the studies that are available currently and what knowledge we can learn from these studies. We're going also to look at the different drugs that are available at our hand now to manage our patient and see and compare how these drugs can be used safely during Ramadan. Okay, this is just an introduction for those maybe who are not Muslim or don't know about Ramadan. You know, Ramadan is a month where all adult diabetics or non-diabetics should fast, except for those who are, let's say, ill or maybe traveling, or maybe a menstruating woman may not fast. Otherwise, all adult Muslims, they should fast from pre-dawn to sunset. And during this time, they should not eat or drink anything. Okay, now we have now more than 1.7 billion inhabitants around the world, Muslims, and out of these, maybe more than 120 million are diabetics. So we have more than 120 million diabetics, and we estimate that out of these 120 million diabetics that are currently available around the world, maybe around 80 to 100 million diabetic fast during Ramadan. And this huge number of patients will definitely need our help to guide them how to fast Ramadan safely. Now, we're going now to look at the studies that are available, which has shown or given us some data about safety of fasting during Ramadan. And the first study, or the most maybe largest study in this regard, is the EBDR study. This is a study which has been run 2005, a bit, maybe more than 10 years back. Now, this is a retrospective study. Patients were asked to fast Ramadan, and then after they fasted Ramadan, a questionnaire was given to the patient, and they had to answer that questionnaire. And the data collected and analyzed, and we're going to see what data we had from this study. Now, this is a multi-center study. It contains patients who are type 1 and type 2 diabetics. It contains males and females. It contains rural and urban patients. So this is a sort of multi-center large study that has been run in 2005. Now, more than 12,000 patients shared in this study. About 1,000 patients were type 1 diabetic, and more than 11,000 patients were type 2 diabetics. Now, in this study, we can see here that almost 50% of the patients had the same physical activity during Ramadan as before Ramadan, and they almost the same food intake, and they gained weight a little bit during Ramadan. But this is not important. What is important is we're looking at the outcome of fasting on diabetics. Now, in this study, as you can see from this slide, there was significant rise in hyperglycemic events and hypoglycemic events. Actually, if you look at this slide, there was about 7.5 increase in the hypoglycemic events during Ramadan. Severe hypoglycemia we're talking here, and also severe hypoglycemia was also increased by about 5-fold. However, and this is very important to know, that the overall incidence, if you go and read that article very well, you will find that the overall incidence of hypoglycemic events was actually rather low in this. So in the EBDR study, there was an increase in severe hypoglycemia, there was an increase in severe hyperglycemia, but the overall hypoglycemic events during this study was rather low. And remember this, because we're going to come back to this again. Now, based on that, in 2005, a recommendation for management of type 2 diabetes was published, and this was published first time, as I said, in 2005, but later on in 2010 this was updated, and a group of physicians from all over the world, they gathered and put this recommendation. And from this recommendation, which, as I said, was updated in 2005, and I was luckily one of the people who shared in this recommendation, the major risk factors for diabetics so fast Ramadan are severe hypoglycemia, hyperglycemia, diabetic ketoacidosis, dehydration, and thrombosis. So these are the hazards that we should really try to avoid when patients fast Ramadan. And of course, to avoid them, we have to do a lot of changes, not only in dose medication, but also we have to educate patient. Number one, how to fast Ramadan safely. So in this article, the patients were categorized as their ability to fast Ramadan into a high-risk patient or very high-risk patient, then a high-risk patient, and moderate risk and low risk, depending on how bad is their diabetes, how many times they were admitted with DKA in the last 3 months, whether patients are living alone or they have support, they have other comorbidities like renal insufficiency, pregnant females, type 1 diabetes. So all these were considered as sort of carrying high risk for patients who do. However, and please take note of this, that all of this article and all of its content was only based on clinical experience. We don't have any evidence in our hand that says that a type 1 diabetic should not fast, okay? But what we feel that a type 1 diabetic, if he wants to fast, then he's at increased risk. That means you need to do maybe a little bit more attention on such patient so that they can fast Ramadan safely. So whatever recommendation that came on that paper is only based on clinical experience, but not on actual facts or figures. And later on, the South Asian group also had put a recommendation. In 2012, I believe, they also did another guideline, which is almost similar to the guidelines that was published in 2010. Okay, now we understand from the EBDR study that severe hypoglycemia and hyperglycemia is increased in patients who fast during Ramadan. Now, what if we teach our patient or educate them how to fast safely? What if we ask them to monitor blood glucose? What if we did some dose adjustment to their medication, or even change the medication and replace it by a more safe medication? What if we teach our patient what to eat and to watch their blood glucose and so on? Now, to answer this, Professor Ahmedani in 2012, he did a very nice study, a prospective study, and he looked at 110 subjects who were educated about their diet, about their medication, and they were asked to monitor blood glucose and so on, and report any hypo or hyperglycemic events. And he wanted to see, would that have any effect on their on them fasting Ramadan? So 110 subjects were there, and about 4,000 readings were taken to this study. Now, when these patients were really educated about Ramadan and how to manage it, only 2% of the readings, only 2% of a 4,000 reading, which is about only 82 readings out of 4,000 readings were in the hypoglycemic range. Now, this is interesting. That means that if we really educate our patient, not only the patient, but also the physicians who educate the patient about the how to safely fast Ramadan, then things a lot improves in terms of outcome of fasting and for the diabetics. Now, not only that, but he looked at the estimated average blood glucose for these patients before Ramadan and after Ramadan. And the average estimated blood glucose before Ramadan was around 224 milligram per deciliter, while during Ramadan it was 165. That means not only these patients could fast safely, but also their blood glucose improved, or the average blood glucose improved during Ramadan. So from this prospective study from Pakistan, the majority of patients did not have any serious hypo or hyperglycemia. Now, this improvement versus what we have seen in the EBIDA study was only based because these patients were educated about their disease. Now, another interesting and beautiful study was done by Professor Malini from Singapore, I believe, in 2014. Again, he wanted to evaluate the effect of Ramadan fasting on Muslim patients with diabetes in relation to use of medication and lifestyle changes. Now, and he studied about, again, a small group, 153 patients who were educated about their disease, and he compared them to patients who were not educated. And look, this is the HbA1c of the patient before Ramadan. It was around 9%. Now, during Ramadan, there was a beautiful drop of the HbA1c to 8.5. And then after Ramadan, unfortunately, this effect was lost. Now, when he compared this to patients who did not receive any education, now the group who did not receive any education, their HbA1c remained all the way the same without improvement. And he concluded that Ramadan fasting appeared to improve glycemic control. Now, we're not only talking about less hypoglycemia or less hyperglycemia, we're talking about an improvement in blood glucose during Ramadan. A very nice study which has also given us more evidence that patient education is very important during Ramadan. Okay, a third study that I'm showing you here has looked again at two groups of patients, a group who had education and another group who did not have education. Now, the group who did not have education, unfortunately, had 4-time increase in the events of hypoglycemia during Ramadan. Now, on the other hand, the group who had education before Ramadan, a structured diabetes education before Ramadan, they had actually a decrease in the hypoglycemic event. Again, giving us further evidence that patient education not only can prevent hypo and hyperglycemia, but also can improve hypoglycemic events and improve estimated average blood glucose of patient during Ramadan. That means to say that an educated patient can actually improve his blood glucose during Ramadan. Okay, a third study, again by Professor Ahmadani, was published about the implementation of Ramadan specific diabetes management. Now, they grouped the doctors and they told them what to do and how to manage Ramadan and how to apply the guidelines that was put by the ADA group. And what he found that when patients were improved, now this is a much bigger population. We have almost 682 patients enrolled in this study, and this is, you can see here, the patient characteristics. Okay. Now, when these patients were educated and their physicians also applied the guidelines, there was only 23% prevalence of hypoglycemia and only 16% of hyperglycemia in these patients. And this was only symptomatic hypoglycemia or documented hypoglycemia. But there was no severe hypoglycemic events or severe hyperglycemic events, for instance, needing hospitalization in this group. Again, he concluded that it is possible to apply guidelines, and if you apply these guidelines, then your patients can safely fast without an increased risk of hypoglycemia or hyperglycemia or diabetic ketoacidosis. From all these studies, we actually learn one thing, one very important thing, that patient and physician education is a very important factor in determining the outcome of patients who fast Ramadan. Now, the last study we're going to talk about is the CREED study. Again, a very recent study, however, a retrospective study published in 2015, again showed that patients can improve in their outcome of fasting if you educate him. Again, this study included both type 1 and type 2 patients. So we have a lot of evidence now which says that, yes, patients can fast provided that you teach them how to fast and you apply the guidelines for them to safely fast Ramadan. Now, in conclusion from the CREED study, that if you adopt multiple approaches, including applying guidelines, providing fasting specific advices, and adjusting treatment regimen, can help patients to fast more number of days without acute complication. That means without severe hypoglycemia, without severe hyperglycemia, without DKA, and without dehydration and thrombosis. All this can come if you really educate your staff and then educate your patient about fasting Ramadan. I'll just give you an example how important is patient education. Now, in a very small study, patients were asked, does bin prick is allowed during Ramadan or not? Unfortunately, if you can see from this slide that almost 70% of our patients, they think that a needle prick in Ramadan is not allowed. You cannot allow. Now, this is a very false, because it is allowed for patients to test their blood glucose. Now, if patients believe that they cannot test their blood glucose, of course that will affect their fasting and the outcome of their fasting. So 70% of the patients said that skin prick is not allowed. Skin prick is allowed only 25%, and few patients said that they're not sure. Now, this is clear evidence that our patients does really need education. Okay, we're talking about education. What is needed for this? What we need is a focused, structured diabetes education. This should include teaching patients and, of course, teaching staff who taking care of your patient. And sometimes you need to do a little bit of a special education for diabetes, like patients who are insulin pumps or so on. Now, almost all of our patients will insist to fast, even if you tell them not to fast. And this is seen all over the Islamic world, okay? Now, this passion to fast could be taken as a chance for the physician or for the educator to teach the patient, okay, if you want to fast, then you have to do this and this and this. And then you educate your patient. You have to tell them about the signs of symptoms of hyperglycemia and hypoglycemia. Blood glucose monitoring is important for all patients who fast. Meal planning is another important factor. Physical activity, medication adjustment or maybe changing from one medication to another is again important. And management of acute complication. Now, if your patient knows all of this, then I'm sure all of your patients can really fast Ramadan, except, of course, maybe those who are in severe renal failure or severe cardiac failure or severe hepatic failure. Otherwise, I believe most patients can safely fast Ramadan. Now, a very important thing which every single diabetic who wants to fast should know is when to break the fast. Now, this is a must. Okay, we have to tell our patients that if blood glucose is under 60 milligram at any time, even if you have just 30 minutes to breaking the fast or Maghrib, then patients should quit fasting and take anything, say juice or something to increase their blood glucose. Because hypoglycemia is a serious thing that we should not allow our patients to suffer. So 60, below 60, you should break your fast, whatever is the case. Now, again, if blood glucose is above 70, but you are in the early hours of fasting, say in the morning, if you get a blood glucose of 70 and you're still in the morning, I think again these patients should also break their fast. Now, in contrast, patients who suffer from hyperglycemia, I would say that they may or may not break their fast. Now, if they are symptomatic, so if a patient has got a hypoglycemia of 300 or more, and he has symptoms of polyuria and so on, then such a patient, yes, should break his fast. Or if he is acutely ill, so a patient who's got, let's say, a pneumonia, any other fever or whatever, a diarrhea and so on, is got a high blood glucose, and he's acutely ill, I think such patients also should break their fast. But if patient has got hyperglycemia because they had a very big meal at sahur time, then it's better to wait, and they're not symptomatic, maybe you allow such patient to look at blood glucose an hour later and see if things are improving, then it's okay. If patients are worsening, then again, they have to break their fast. Now, we're going to look at the different drugs that are in our hand at the moment and which evidence we have on this drug in patients who fast Ramadan. Now, I'm going to quit this slide. Now, the first slide we're going to look at is the patient on sulfonylurea. Now, we shared in a study looking at different sulfonylureas used during Ramadan, and we wanted to see hypoglycemic events with different sulfonylureas in Ramadan. And unfortunately, as a whole, sulfonylurea, about 20% of our patients will have symptomatic hypoglycemia during Ramadan because of sulfonylurea use. Now, this is very important, and the case is not the same for all of this. So some sulfonylureas had less events. The highest was glipizide and glibenclamide, which I should believe that they should not be used during Ramadan, while glycoside and glimepiride, they had a lower frequency of hypoglycemia. So sulfonylureas is not very safe during Ramadan, especially for patient who had a low HbA1c. So a patient who's got an HbA1c of 7, I think sulfonylurea for him is more risky for a patient who's got an HbA1c of 10 or 8 or something like this. So the more control the patient has, the more he is expected to have hypoglycemia if you use sulfonylurea. And this is, again, a multi-center study. The huge number of patients enrolled in this study. And we happen to be one of the centers that in Mecca who shared in this study. Now, severe hypoglycemia was almost equal between different types of sulfonylureas. But symptomatic or documented hypoglycemia was more with glibenclamide, more with glipizide than glimepiride or glyclazide. Now, another study that we did or we shared in is when you now shift patients from sulfonylureas to a DPP4 inhibitor. Okay, and we know that DPP4 inhibitor has a lower frequency of hypoglycemia because of its action is dependent on meals, dependent on the blood glucose level. Because of that, now we have found that when you switch patients from sulfonylurea, different sulfonylurea, we use glyclazide, glimepiride, and glibenclamide. Now, if you use these drugs and then you switch your patient into two groups, a group which continued in metformin and sulfonylurea, and another group continued on metformin now and a DPP4 inhibitor. In this case, it was sitagliptin. There was almost a 50% reduction in the events of symptomatic hypoglycemia. That means when you change from sulfonylureas to a DPP4 inhibitor, you can reduce the events of hypoglycemia by about 50%. And this was seen with sitagliptin and also seen with other DPP4s like vildagliptin. So both of these DPP4s were actually studied in patients who fast Ramadan and found to be safe with a lower frequency of hypoglycemia. Now this is only this reduction was only in symptomatic hypoglycemia. So that there was about 43 events in patients who are on sitagliptin versus 92 events on patients who are taking sulfonylurea. But severe hypoglycemia or hypoglycemia requiring medical assistance or medical hospitalization was much less in both groups. Now, one sulfonylurea may be different from other sulfonylureas, and that is glyclazide. Because in another study that we did, again comparing DPP4 sitagliptin versus other sulfonylureas, but here we use the modified release glyclazide or glyclazide MR. Actually, the group on glyclazide MR had a similar frequency of hypoglycemia to the group on sitagliptin. But as I said before, not all the sulfonylureas are the same. So the worst in terms of hypoglycemia is glipizide, then glibenclamide, then glimepiride, and the best is glyclazide MR. Okay, also not only sulfonylureas, but also repaglinide was also studied in patients who fast Ramadan, and that was compared to glibenclamide. Remember, we said glibenclamide has the highest or the worst events of hypoglycemia. Now, they compared glibenclamide to repaglinide in a study by Professor Mafosi, and it was found that type 2 diabetics are using prandial repaglinide. You know, repaglinide has to be taken, let's say, before meals. So if you use repaglinide before iftar and before sahur, that gives you a better outcome in terms of hypoglycemia comparing to glibenclamide. Then we have the other study comparing bioglitazone and the use of bioglitazone in patients who fast Ramadan. And the patient we grouped into two groups. A group were continued on oral medications plus placebo, and the other group was continued on all other oral hypoglycemic plus bioglitazone. And you can see now the difference in the fructosamine level between the group on fructosamine plus placebo versus those who are on oral hypoglycemic plus bioglitazone, and it was shown that there was similar efficacy with no increased frequency of hypoglycemia in patients who use bioglitazone. But remember again that if you want to start patients on bioglitazone, then you do this at least 2 months before Ramadan, because you know that this drug has got an accumulating effect. So by the time Ramadan comes, then the drug has got very good efficacy. Now, this is again talking about different studies in patients who fast Ramadan. This is randomized control trial comparing GLP-1 receptor agonist liraglutide to sulfonylurea. Again, here it was found that liraglutide can also be used during Ramadan, but again, you have to be careful to use it a bit earlier, 2 months at least before Ramadan. Now we talk about insulin, and all insulin the same during Ramadan. Actually, we don't have a clear-cut answer to this. Which insulin regimen is best for our Muslims who fast is not very well known to us. But I will show you now a study which, this is a study comparing insulin lispro mix 25 and human insulin 30/70 in the treatment of type 2 diabetics during Ramadan. And in this study, it was found that when you compared to human insulin, the 30/70 mix, which is an insulin analog, or the mix 25, resulted in a better range of glycemia, indicating that yes, you maybe replace human insulin with insulin analogs during Ramadan. Now, in summary, for the drug if used in Ramadan, we can say that based on the current evidence, the following should be considered when you select your therapy for your patient. Number one, metformin is safe in fasting and non-fasting individuals. Metformin is the standard golden therapy for type 2 diabetes. Should always be there in fasting and non-fasting individuals, of course, unless contraindicated. DPP-4 inhibitors have got a low risk of hypoglycemia, and we have shown you that you can reduce hypoglycemic events by about 50%. Now, glinides, again, can be used. Sulfonylureas have a higher risk, and not all sulfonylureas are the same. The worst is glibenclamide, and the best maybe is glycoside MR. Bioglitazone can be used in Ramadan, but will lead to weight gain. GLP-1 receptors again can be used, but you got to be using them way ahead before Ramadan. Now, in conclusion, what we want to say here that we do really need more randomized clinical trials is needed to assess the safety of fasting of different types of diabetes. The rates of hypo and hypoglycemia events vary in different studies. In one study it is more, and one study is less. So local studies gives a better image. I would advise local studies than international studies or multi-center studies. The reason is that you study your population and you have to study your climate. You have to study the hours of fasting. Could be different. If you are in Saudi Arabia, for instance, maybe hours of fasting may be 13 or 14. But if you are somewhere in Europe, the hour of fasting may be 18 hours or 19 hours. Now, how can you compare two people, one fasting 14 hours and the other fasting 18 hours? There's no way to do that. So the better is to have a local study. Now, the safety and efficacy of different therapies in fasting diabetics has to be more investigated, and I think we all should share in this. We all should try to find what is the best insulin regimen, what is the best drug to use during Ramadan, and what is the best sort of lifestyle that patients should apply to fast Ramadan safely. Now, the only evidence that we are sure of, and we can say that is proved beyond doubt, is that structured diabetes education for patients and healthcare providers has a vital role in fasting safely in patients with diabetes during Ramadan. Thank you very much. وكل عام وأنتم بخير.